Assalamu alaikum, ladies and gentlemen. I am Dr. Mujahid Aslam, working as Assistant Professor of Gastroenterology in Leading Hospital, Peshawar. It's my immense pleasure and honor to welcome you all to the final session of the 41st Annual Conference of Pakistan Society of Gastroenterology. For the past few days, we have experienced an intellectual stimulating journey featuring hands on workshops, state of the art lectures, interactive quiz, and thought provoking abstract presentation. While the schedule has been intensive and we feel the toll of the packed academic agenda, I assure you that this final session will be both engaging and clinically impactful. Today, we will focus on a topic of immense relevance in the day to day practice, that's dysphagia, a symptom with multiple causes. We are privileged to have some of Pakistan's most respected names in gastroenterology with us, who will be sharing their insights into the diagnosis and management of various benign esophageal disorders. Before we begin, I would like to invite the chairs of the session to the stage. First, Professor Dr. Khalid Hamid. He is a professor of gastroenterology in Kabir Medical College. Professor Dr. Adil Nasir. He is professor of gastroenterology in Ayub Medical College. Dr. Rajesh Kumar Wadhwa. He is assistant professor in Liaquat National Hospital. Dr. Asma Asghar. She is consultant gastroenterologist in Peshawar. Dr. Shahab Abid. Thank you for the esteemed chairs for joining us and helping guide today's proceedings. Let's now begin with our first talk, focusing on a condition that has been gaining increasing attention in clinical gastroenterology, that's eosinophilic esophagitis. This lecture will be delivered by Professor Dr. Shahid Rasool. He is Professor of Gastroenterology and Head of Department of Gastroenterology and Hepatology in Medina Teaching Hospital, Faisalabad.
Bismillah ar-Rahman ar-Rahim. I'm very thankful to the organizers, Dr. Kamran, Professor Sher Rahman, for giving me this opportunity to talk in the last session of PSG. And I will be talking about a condition which is, I think, one of the most underdiagnosed condition in our part of the world, that is eosinophilic esophagitis. And I was given the task to talk about some of the recommendations about eosinophilic esophagitis. This is my disclosure. However, I will disclose that as I was given the task of the recommendations, and the most of the recommendations I will be talking about during my talk are taken from the latest guidelines of the ACG clinical guidelines for the diagnosis and management of eosinophilic esophagitis. So, ladies and gentlemen, eosinophilic esophagitis is a chronic allergen-induced type 2 immune-mediated disease of the esophagus, which is characterized by the symptoms of esophageal dysfunction and an eosinophilic predominant infiltrate in the esophagus. The condition is rapidly increasing in incidence and the prevalence, likely because of the environmental factors interacting with the genetic and the epigenetic changes. What was once a case reportable and rare disease has become a frequently encountered condition in the gastroenterology and the allergy practices, but possibly we are just seeing the tip of the iceberg of eosinophilic esophagitis, especially in our part of the world. But I have seen that we are not basically aligned to think and diagnose this disease. So when we come to the definition, eosinophilic esophagitis is diagnosed with the following three criteria: symptoms of the esophageal dysfunction, at least more than 15 eosinophils per high power field on esophageal biopsy, and an evaluation for the non-esophageal esophagitis disorders that cause or potentially contribute to the eosinophilia. So there are some other conditions which mimic with this, and they may have some eosinophils in the biopsy, and these should be considered while you are diagnosing. These are the GERD, pill-induced esophagitis, drug hypersensitive reaction, hypereosinophilic syndrome, Crohn's disease. So this is the first recommendation from the ACG, that we recommend that eosinophilic esophagitis is diagnosed based on the presence of the symptoms of the esophageal dysfunction and at least 15 eosinophils per high power field. As I already said, this is an immune-mediated disease initiated when the allergens interact with and penetrate an esophageal barrier that has intrinsic and the acquired effects. with eosinophils acting as one of the number of the pathogenic effector cells that lead to the clinical manifestations of inflammation, remodeling, and later on fibrosis. In the setting of diagnostic delay, untreated or incompletely treated disease, eosinophilic esophagitis may progress from an inflammatory to a fibrostenotic phenomenon in most but not all the cases. So it's very important to diagnose it early and treat it early. Otherwise, the patient may end up with the fibrostenotic component of this disease. This is the natural history, starting from simple inflammation and then ending up with the fibrostenotic disease. And there are certain studies which showed at the time to diagnose the reflected risk for the stricture and the food infections. And with each additional years of the symptoms, without diagnosis, the stricture risk increases about 9%. The clinical presentation is very different, and it basically depends on the age. In infants and the younger children, poor growth, failure to thrive, feeding intolerance, failure to progress to the solid foods, increased time needed for eating, or the food refusal may be the presenting symptom. When you come to the school-age children, abdominal pain, vomiting, regurgitation, and heartburn are common. All symptoms of the eosinophilic esophagitis are non-specific, has a broad differential diagnosis. As you can see, these are the symptoms which are very non-specific. When we come to the adolescents and the adults, dysphagia and the food infection are most common, although heartburn and the chest pain can be present as well. So as I have discussed, the clinical presentation is very common. Clinical presentation की base पे diagnose नहीं कर सकते because are the very non-specific symptoms. Symptoms of esophageal dysfunction, and then where the impact behavior to assess while taking a dysphagia history. जब dysphagia की आप लोग history ले रहे होते हो, तो you have to ask some questions like imbibile fluids, drinking a lot of liquids to help get each bite down smoothly, modify foods, cutting foods into the small pieces, prolong meal times, avoid higher texture foods, meats, crusty meats, and the children, they start avoiding this meal, chew excessively, and turn away tablets. The hallmark of to diagnose is the EGD with the biopsy. And we have to the findings of the endoscopy properly. I will discuss that. When we have the esophageal biopsy and the biopsy who is taken properly and it shows more than 15 high power fields, then to make a diagnosis of eosinophilic esophagitis. These are the different findings on endoscopy, starting from the rings, furrows, edema, exudates. There are multiple findings which you can see on the endoscopy. And when you are reporting the endoscopy, that is very important that the endoscopist should report the findings properly. And there is a score which is called eosinophilic esophagitis endoscopic reference score. So that contains the different variables like edema, rings, exudates, furrows, and strictures. And they have given these specific numbers, like edema is present, it will be E1. If the rings are mild, it is R1. If the moderate to severe, this is R2. And with the severe rings, then it is R3. Exudates is less than 10%, it is E1. And if more than 10%, they are E2. If the furrows less mild, 1, and then the furrows are severe with 2, and the stricture is present, that is the S1. So the ACG recommends that we recommend using a systemic endoscopic scoring system to characterize the endoscopic findings of eosinophilic esophagitis at every endoscopy. So this is a strong recommendation that whenever an endoscopist is thinking of eosinophilic esophagitis, he or she should document the findings properly in this structured manner. Then taking biopsies, we recommend obtaining at least 6 esophageal biopsies. तो हमारे यहाँ आमतौर पे ये होता है कि पहले नंबर पे तो हमारी जो एंडोस्कोपिक फाइंडिंग्स होती हैं, तो जब हम रिपोर्ट देखते हैं तो मेजॉरिटी ऑफ द टाइम अगर कहीं लिखा होता है तो रिंग्स का जिक्र हो जाएगा कि देयर आर सम रिंग्स. edema, furrows के बारे में आमतौर पे बात नहीं मिलती. And then when you have to take the biopsies, it is a recommendation that you should take at least 6 biopsies, 2 from the distal end, 2 from the middle end, and 2 from the upper end. That is the proper way of taking the biopsy. So ACG recommends that at least 6 esophageal biopsies from at least 2 esophageal levels should be taken to assess for the histological features consistent of eosinophilic esophagitis. And they recommend that the eosinophil counts be quantified on the esophageal biopsies from every endoscopy performed for eosinophilic esophagitis. And I will also say, whenever you're sending a biopsy to the histopathologist, kindly mention over there that this is in my mind, that possibly this patient is suffering from eosinophilic esophagitis, जो हमारा histopathologist है, ताकि उसको भी ये हो कि what he or she have to look into the biopsy. Coming to the management aspect, the goals of eosinophilic esophagitis treatment are to improve the patient's symptoms and quality of life, improve or normalize the endoscopic or the histological appearance of the esophagus, normalize growth and development in the children as mostly they are present in the childhood, maintain the nutrition and prevent the complications such as food impaction, esophageal stitching, and perforation. To do this, both the inflammatory and the fibrostenotic aspects of the disease need to be addressed. So these are the 3 management pathways, that is the diet, drugs, and dilatation when it is required. When the patient presents in the fibrostenotic component, then we have to do the dilatation. Coming to the drugs, the pharmacological, the dietary therapies can treat the inflammatory component and can also lead to the improvement in the esophageal caliber. Esophageal dilatation is used to treat strictures and the luminal narrowing. Because the field lacks the comparative efficacy clinical trials for the different treatment approaches, the decision of which treatment to be used is individualized based on the disease characteristics and the patient preference using a shared decision-making framework. The first drug which we can use to treat the eosinophilic esophagitis is proton pump inhibitors. किसी ज़माने में आज से जो प्रीवियस गाइडलाइंस थी तो ये ट्रीटमेंट से कंसीडर करने से ज़्यादा इसको इस्तेमाल किया जाता था to exclude and make a diagnosis, but now it is a definitive treatment for eosinophilic esophagitis. And the rationale for the using PPI for treatment of eosinophilic esophagitis goes beyond the anti-secretory. It is not only the anti-acid properties which we use for the treatment of eosinophilic esophagitis. PPIs have multiple effects beyond the blocking the proton pump inhibitor and in eosinophilic esophagitis. Several potential novel mechanisms have been described, including the decreasing the expression of the eotaxin 3, improving the esophageal barrier function, and helping to maintain the esophageal epithelial transcription hemostasis. It is important to explain this rationale to for PPI use to the patient with eosinophil. इसका क्या मतलब हुआ कि हम मोस्टली जब गर्ड वाले पेशेंट्स होते हैं, जब वो स्टेबल हो जाते हैं, हम उनको कह रहे होते हैं कि यार अब ऑफ एंड ऑन PPI इस्तेमाल कर लो. But when you are dealing with a patient of eosinophilic esophagitis, here you are not using it for the reflux. Here जैसे मैंने कहा कि हमने इसकी जो फाइब्रोस्टेनोटिक कंपोनेंट है उसको भी बचाना है, तो here you have to take the PPI for longer period, so they are not confused by the well-known reflux indication of this medication class and in turn have compromised adherence. There are few studies available. This study with 42 adults of eosinophilitis was randomized to esomeprazole 40 milligram daily or the fluticasone swallowed from an inhaler device. There was no significant change in the biopsy of esophagus count, but the 33% of the patients reached the endpoint of less than 7 eosinophilic esophagitis. That is the histological improvement. ये पेशेंट थे जिनको at the start they have more eosinophils and then they completed the study, the eosinophil count in the biopsies decreased. Dysphagia symptoms measured with the myodysphagia questionnaire score significantly improved with the esomeprazole therapy. Similarly, there was an improvement in the endoscopic signs of eosinophilic esophagitis, including the stenosis, rings, furrows, and plaques. So from a practical standpoint, we suggest initial treatment of eosinophilic esophagitis with high-dose PPI, essentially using doses that are double the approved reflux dosing, and either once daily or the divided doses before meals can be used. Histological remission was significantly higher with 20 to 40 milligram twice daily dosing, and so the ACG recommends that PPI is the treatment of eosinophils in the first hand. Then the second, which was previously the number one drug, was the topical steroids. Swallowed topical steroids was the first medical therapy for eosinophilic esophagitis with clinical effectiveness. The concept was to coat the esophagus with an anti-inflammatory medication which will prevent eosinophilic esophagitis. Focusing on the recent trials of the swallowed topical steroid, histological efficacy defined by achieving less than 15 eosinophils per field will range from 62 to 95 of the trials of the budesonide oral suspension or the budesonide oral dispersible tablets. Unluckily, these tablets are not available in Pakistan. Another pharmacological agent has been used is the fluticasone orally dispersible tablet, reported histological response in about 75% of the cases. For this recommendation statement, the quality of evidence regarding the swallowed topical steroids for histological improvement and remission is high, but for other endpoints, the evidence is moderate to borderline. So the ACG recommends that the use of the swallowed topical steroids as the treatment of eosinophilic esophagitis, and they recommend the use of the either fluticasone or the budesonide in patients with eosinophilic esophagitis being treated with the topical steroids. There is a new class of drugs जो अभी start हुई है. The one of the drugs, the dupilumab, is monoclonal antibody against the interleukin 4 receptor that blocks the effect both of the interleukin 3 and interleukin 4 cytokines that are the central to the type 2 inflammatory cascade. So this medication with subcutaneous injection has been previously approved in the other different diseases. So this drug has also been used for the treatment of eosinophilic esophagitis, and they have recommended this for the use in eosinophilic esophagitis. So ladies and gentlemen, these are some of the drugs, PPIs, topical steroids, and the different doses. And then the biomodulator drugs. Another very important thing for the treatment of eosinophils is the dietary elimination. Knowing that the pathogenesis of eosinophilic esophagitis is food antigen driven in most people provides the foundation for dietary elimination treatment. Dietary therapy was first found to be effective for eosinophilic esophagitis in 1995. So in the preliminary studies, although 72% responded histologically, symptoms did not improve significantly. There are the previous studies, there is histological improvement, and then there is a data that there is symptomatic improvement. Of the empiric diet therapies available for eosinophilitis, the 6 food elimination diet has been the best studied. For this diet, the common allergens of the animal milk, like dietary products, dairy products, wheat, soy, egg, nuts, peanuts, and the fish, shellfish are empirically removed. Different prospective studies of the patient with the eosinophilic esophagitis demonstrated that 70% achieved histological remission and they reduced the symptoms. Wheat and the milk were the most implicated food antigens after reintroduction. There is another concept of step-up approach that in spite of, rather than using the 6 feed elimination diet, we can use the 4 elimination diet, 2 elimination diet, or the 1 elimination diet. Step up approach or the step down approach जैसे अस्थमा में किसी ज़माने में इस्तेमाल होती थी, where we can use it in eosinophilic esophagitis as well. The step up empirical elimination diet for the pediatric and adult eosinophilitis, the 2-4-6 study, and the overall effectiveness was elemental more than 90% than the different drugs and the food elimination. So the food elimination diets are effective for the long-term treatment of adults with eosinophilic esophagitis. So on the basis of this data, the guidelines came as we suggest that an empirical food elimination diet as a treatment of eosinophilitis, and we do not suggest currently available allergy testing to direct food. तो जो different allergy tests available हैं, उसकी base में हम ये फैसला नहीं कर सकते. We have to make the diagnosis, we have to take the biopsies, और उसके बाद we can empirically go for the food elimination plan for the treatment of this case. So this is the algorithm. Eosinophilic esophagitis, establish, treat inflammation, and assess for the fibrostenotic in all cases. Anti-inflammatory treatment we have in the form of the pharmacological treatment, PPIs, the topical steroids. Then we have the diet elimination treatment, empirical elimination, assess the response. अगर आपको response मिल रहा है, fair enough, you maintain this. Response नहीं मिल रहा, you can go for the biological. लेकिन अगर आपको ड्यूरिंग द सिम्टम्स और एंडोस्कोपी के दौरान आपको स्टिचिंग डिजीज मिल जाती है, स्टेनोसिस मिल जाती है, स्टिक्चर्स मिल जाते हैं, देन डेफिनेटली यू हैव टू गो फॉर द डायलिटेशन. सो द क्वेश्चन इज व्हेन टू डायलेट एंड व्हेन टू ट्रीट. देयर आर randomized control trials, dilatation to medication, and the studies those with a lumen greater than 7 millimeter. Primary outcome was dysphagia scores And in most of the cases, we have to do the dilatation as well as the pharmacological therapy. And esophageal stricture is often viewed as a transmural or the fibrostenotic process, and in esophagitis, focal constrictions of the esophagus as well as more diffuse and longitudinal narrowing may be seen. Studies using endoscopic ultrasonography have demonstrated expansion of the esophageal mucosa, submucosa, and the muscularis propria in patients with eosinophilic esophagitis. It is likely that the esophageal wall thickening in eosinophilic esophagitis is composed of the both inflammation and fibrosis. So the effectiveness and safety of dilatation in patients with eosinophilitis were detailed in systemic reviews and the meta-analysis. Clinical improvement occurred in 95% of the cases, and the post-procedure hospitalization occurred in less than 1%, and esophageal perforation less than 0.5% of the dilatation. So it's quite a safe procedure to dilate those patients who require the dilatation. So what they have recommended is we suggest the use of the endoscopic dilatation as an adjunct to the medical therapy, to treat for the esophageal strictures causing dysphagia in patients with eosinophilic esophagitis. So when we talk about the management response, we have patients who have non-responders. We patients, with majority of the patients, they respond to different therapies, and there are some patients who have complete normalization in the form of the symptoms, then the histological improvement, and then the important thing is the maintenance therapy. Because this is an autoimmune type disease, so we need the maintenance therapy. The rationale for maintenance therapy in eosinophilitis is based on the natural history as a chronic disease. When eosinophilitis treatment is stopped, disease activity nearly universally recurs, regardless of the type of treatment. So we have to give the maintenance therapy, and the recommendation is that continuation of the effective dietary or the pharmacotherapy for eosinophilic esophagitis to prevent the recurrence of the symptoms, histological inflammation, and the endoscopic abnormalities. So the median time to the clinical symptom relapse was also longer in the budesonide group compared with the placebo. Prospective and the risk-spread cohort data also support maintenance therapy with the topical steroids. In general, it is reasonable to consider dose reduction with steroids to use the lowest, most effective dose confirmed by endoscopy. Data also support the long-term efficacy of the PPI and the dietary elimination in eosinophilic esophagitis in both the children and the adults. Monitoring is unluckily, there is no test to monitor. जो इनकी recommendation है, when I was going through, they were asking every 12 weeks you have to do the endoscopy, you have to look for the endoscopic findings, you have to take the biopsy and look for the eosinophil count. That is very cumbersome. Currently, response assessment in eosinophilic esophagitis relies on the endoscopy with biopsies, although there are no non-invasive biomarkers. So, ladies and gentlemen, this is my last slide, that the eosinophilic esophagitis is not uncommon, and it should be in the differential diagnosis list in all patients with the esophageal symptoms. Endoscopy, proper biopsies, and histopathology is the gold standard for diagnosis, management, and monitoring. Topical steroids, PPI, and the feed elimination diets, along with dilatation, are the cornerstone of treatment. Long-term maintenance treatment and the follow-up is required. If managed properly, timely, the long-term prognosis is very good. Thank you very much.
Thank you, Dr. Shahid Rasool, for that insightful and well-structured overview of eosinophilic esophagitis. We now move on to our second presentation, which will address the endoscopic management of peptic strictures, a common and often challenging cause for benign dysphagia. To speak on this, I invite Professor Dr. Mashood Ali. He is Associate Professor of Gastroenterology and HOD in PIMS.
बात सुनो इससे होगा अपने ठीक है Assalamu alaikum. Bismillahirrahmanirrahim. Thank you very much for Professor Kamran, Professor Sher Rahman, and their organizing team for inviting me for this presentation. My topic is peptic stricture endoscopic management. As we all know, peptic strictures are very common. And the presentation layout is introduction, initial evaluation, and stricture characterization, role of acid suppression, endoscopic therapies, which is our main focus, and surgery and other upcoming modalities, local disease burden and experience. Peptic strictures are the most common type of benign strictures, but in our part of the world this is changing, and we know the physiology, all of us very well know. Uncontrolled gastroesophageal reflux, acid exposure ultimately leads to scarring and stricture formation. What is important is initial evaluation and characterization of the stricture is important. Perform an endoscopy to evaluate and classify the stricture type and rule out any concomitant pathology like especially malignancy. If the strictures appear complex, cannot be traversed, you can use fluoroscopy, barium studies to find localization, extent, and the characteristics of the strictures. And it is worth mentioning that ultra slim scopes are very useful in strictures, traversing the strictures, but you can miss the stricture, even underestimate it. So it is best to do the initial endoscopy with a regular endoscope to avoid these. The strictures, peptic strictures could be simple or complex. Simple strictures we know short, usually short focal, straight, non-angulated, located in the distal third of the esophagus, typically resolve with 3 to 5 sessions of dilatations, whereas complex strictures may be multiple, irregular, may be angulated, variable sites, don't resolve usually with routine endoscopic dilatations. And these can coexist with erosive esophagitis, Barrett's esophagus, and sometimes we need to rule out malignancy while taking biopsies. Role of acid suppression is the cornerstone of peptic stricture management, and this trial was done in 1994, where H2 blockers and PPIs were used, and since then many trials have been done, and these have acid suppression has a definite role in stricture prevention and its recurrence. Endoscopic therapies, which are the mainstay of treatment nowadays, and bougie dilators through the scope balloons and Maloney dilators. These are usually used and mainly for the simple strictures which we encounter, and these dilators we use normally. If the strictures are refractory or recurrent, then we can give intralesional steroids, stent placement, and surgical interventions sometimes would also be required. Add, add on therapy for all types of modalities, PPIs should be given. What should be the decision? Select type of endoscopic therapy. Three things are important. The assessment of stricture, simple versus complex, whereas length and the distal extent of the stricture. To know the length and distal extent is very important. Sometimes one can cause perforation if he don't know about the length and distal extent of the stricture, and the experience of the endoscopist and the facility available. Endoscopic dilatation, we use bougies or TTS balloons, and which is common all over the world. And bougie dilators, typically we need multiple passes to achieve the desired dilatation. And these rely on the tactile sensation of the endoscopist to assess for the stricture dilatation. You need to feel the pressure. How much is the pressure? Especially for the beginners, it would maybe, one has to feel the pressure. If it is moderate pressure, then one has to, you know, uh, feel it, and it is tactile sensation, and this with this one can avoid perforation with bougie dilators, whereas bougies have the advantage of exerting both longitudinal force and radial force as compared to balloons that only exert radial forces. TTS balloons are dilatation can be performed under direct visualization, and TTS balloons are especially preferred for complex strictures, very tight angulated strictures where targeted therapy is required for optimal dilatation. Types of esophageal dilators already discussed, but one thing mentioning here is rule of 3 with bougies, and for the beginners, for experienced people, there is no matter using these rules. This is a recent meta-analysis confirmed that there was no significant difference between bougie and balloon dilators of benign esophageal strictures regarding symptomatic relief, a recurrence rate at 12 months, complications like bleeding and perforation, and risk of perforation is less than 5 in 1,000 cases, which were done in this meta-analysis, and the complication rate was equal in both types, either bougie or balloons. And in literature, there is no data to support one over the other for efficacy or safety. The use of either one of these modalities remains the discretion and expertise of the endoscopist, as well as the nature of the stricture itself. Already discussed, and this is about Maloney dilators. This is not very common nowadays, and these are blind dilators, mercury filled, which we can use for simple strictures, and people can do self dilatation, but in our part of the world it is not common, rather common in street performers for attracting the crowds. Rule of 3 while performing dilatation, a technique that is widely accepted but not formally validated. In this, we use dilators, not more than 3 dilators of successively increasing diameter. And this rule does not apply to balloon dilators. Carefully graded dilatation could perform while monitoring mucosal tears. And although superficial tears are common and expected after effective dilatation, deeper tears and perforations needs to be addressed. And for that, one has to do CT or esophagogram, followed by endoscopic closure of the defect if possible, either using endo clips or the scope clips or covered stents. Endoscopists, this is important, endoscopists routinely performing dilatation should also learn and know how to manage common complications including bleeding and perforation. When to use fluoroscopy? Fluoroscopy in complex peptic strictures, failure of endoscope to pass the stricture, fluoroscopy is extremely important, where one has to characterize the length and the diameter of the stricture, and to rule out presence of any fistula, and one can pass the wire into the stomach as well. It can also help esophageal lumen to assess the esophageal lumen after dilation, stand position when placed, and contrast extravasation when perforation is suspected. And when to use intralesional steroids. This is again in refractory or recurrent strictures. We use steroids normally, and steroids we know inhibit the inflammatory response and consequently reduce the stricture formation. The steroid used normally routinely is triamcinolone, injected in a 4-quadrant fashion into the stricture during endoscopic dilation sessions. Limitations are there is risk of adverse events like candida esophagitis, and steroid injection in conjunction with anti-secretory therapy and dilations reduces the number of repeat dilation and increases the dilatation-free period. Whereas stent placement we commonly do in malignant strictures, but in benign strictures, their use is limited. But if the stricture is refractory or recurrent, then one can place stent for 6 to 8 weeks, or you can prolong the period up to 12 weeks. Longer placing stents for longer periods, more than 12 weeks, may cause embedding of the stent, and one has to remove the stents timely. And these could be removed after satisfactory improvement and resolution of the stricture. Success rate is 35 to 45%. Migration rate is 25 to 35, and adverse event 20 to 25. Biodegradable stents are also available and an alternative option, but currently their use is limited because of availability. Surgery is rarely needed for peptic strictures, and only after exhausting all endoscopic efforts or associated complications like chronic fistula. With the increasing use of aggressive dilatation, steroids, stents, and the use of surgery is becoming a rare occurrence. Upcoming modalities. Bougie cap, a cone-shaped cap. This is a new modality being used for some years, but short-term studies showed this device showed efficacy about 96% cases of benign complex, along with a significant decrease in the dysphagia scores. Where this cap is promising, it has side holes for suction, and the wire can also be passed through its tip till the stomach, so one can not lose the direction, and one can see the dilatation during tears during procedure, so he can avoid perforations. So good addition in the armamentary of endoscopic equipment for dilatations. Upcoming modalities, again, endoscopic incisional therapy, where we use needle knife or endoscopic scissors for short, peptic strictures, which are short, shelf-like, and membranous rather than long and tapered. Incision can be given, or needle knife can be used, followed by dilatation with balloon, and these limited data suggest that this treatment option is safe and effective, with the results superior to dilatation alone. Antroduodenal strictures, which are also mostly benign and peptic, The mainstay of therapy is PPIs, H. pylori eradication, and followed by, TTS balloons, and the only method of dilatation in this case, limited role of steroid injections, and endoscopic ultrasound-guided gastrojejunostomy is a preferred method if TTS balloons fail, and surgery resection, surgical bypass for also we have these options as well, and no role of bogies for antral dilatations, and SEMS covered, uncovered for malignant strictures are available. Now we will talk about the local disease burden and experience. And as I said earlier, we don't come across the peptic strictures mostly. Now we come across caustic-induced strictures usually. And we had published this article, and this is our publication, where in developing countries, especially in Pakistan, especially in this northern part, in Islamabad, we receive daily emergency cases of caustic-induced injuries. People take caustics for suicide or para-suicide purposes, and this leads to later on development of the strictures, and mostly complex upper GI strictures, including esophagus, stomach, duodenum, so causing a major public health burden concern. And these are common and more comparable to simple reflux-induced peptic strictures. And this data shows the 23-24 from PIMS endoscopy unit GI stricture data, where total 152 patients were encountered, and among them, caustic injury-induced strictures were 84. Patients had caustic-induced strictures, 55% of the total, whereas females were predominating this 98%, 64.5% of the total caustic-induced strictures, and the esophageal peptic strictures were only 24, 15%, and the antral peptic strictures were 6, 3.9%. Here is a case, 32-year female with progressive dysphagia. She denied caustic injection, but it seemed that she took a caustic which caused this stricture. This is not the initial picture. She had a pinhole esophagus. Initial dilatation was done with a 12 mm balloon, followed by second session with this 15 mm balloon. And she is doing well at the moment. She may need further dilatations, so may need steroid injections in future as well. And this case was 64-year-old male with history of reflux and dysphagia. And this patient had long-standing history of use of PPIs, antacids, but there were no signs of reflux here. Rather, it looked eclasia or pseudo-eclasia type to me. We took biopsies, and which were negative for malignancy, and scope was not negotiable through this structure. And a CT scan was also done. There were no signs of malignancy. So one dilation session with 18 mm balloon, and he did well, and he is doing well. This is the last slide, which is important, and 42nd PSG Annual Conference will be going to be held in Islamabad, April 10 to 12, Serena Islamabad Hotel. All of you are welcome there. And thank you very much.
Thank you, Dr. Mashood Ali, for sharing your valuable experience and practical strategies in managing peptic strictures endoscopically. Our final talk of the session focuses on a crucial yet often under-discussed area, that's esophageal manometry. To demystify this important diagnostic tool, we have Dr. Tayyab Saeed. He is a consultant gastroenterologist in Holy Family Hospital, Rawalpindi. He is a special interest in neurogastroenterology. He is performing motility testing for the last 10 years for GI.
Bismillahirrahmanirrahim. Thank you very much, PSG, for inviting me. Last talk, a little bit boring, but please bear it with me. I have divided the talk into three different portions, manometry, then the impedance, and then the pH. So starting with the manometry, manometry has evolved from water perfused to solid state system. So water perfused was the older one, and now we have a much compact solid state system. But the basic principle is the same, that the manometry system consists of a catheter that we pass transnasally or orally with multiple pressure sensor channels on it. There are pressure transducers connected to that, and there is a recording device with the computer for the analysis. With the older system, this sort of graphs many of you would be familiar with a pressure along the y-axis and time along the x-axis. So this is a two-dimensional conventional topographic plot where after a wet swallow, there is a pressure propagation wave along the body of the esophagus, and during that swallow, the LDS laxes. Now just let me add a z-axis to this graph by adding the sensor positions, upper esophageal most proximally placed and lower esophageal most distally placed. As all 36 sensors present in the solid state are at 1 centimeter distance, providing simultaneous information, let's apply more compact time and pressure contours line for the finer details. Now, if you add colors to this graph, where the warmer colors are the higher pressure and the cooler colors are the lower pressure, the concept basically evolved from the weather forecast system. And removing the graphic details, this is the only color coding system we left, and converting back the 3D image to the 2D image, this is actually how the high resolution manometry plot looks like. So actually it can be easily compared with the old two-dimensional graph because the basic principle is the same. The HRM measures the circular muscle function of the esophagus, including the upper esophageal sphincter zone, followed by the esophageal body, with an initial striated muscle zone, then a transition zone, and then the smooth muscle zone. Finally, the lower esophageal sphincter bar. But remember that in the lower esophageal sphincter, the pressures are technically sum of three different measures. One is the lower esophageal sphincter pressure itself. The second one is the pressure generated by the right crust of the diaphragm. And the third one is the sling and clasp fibers of the middle layer of the gastric cardia. So it is very important while performing the manometry that the tip or the distalmost sensors of our probe should be inside the stomach. And to assure that, there is the concept of pressure inversion point, also known as the PIP, or you can say a respiratory inversion point, and which is produced by the diaphragmatic movements during the respiration. So with the respiration, you can easily find, with deep inspiration, easily it reveals a PIP on the HRM plot. Hence, they are used as a landmark to locate the lower esophageal sphincter. Closely looking at the graph, you can see that during inspiration, the intrathoracic pressure that decreases with lighter color, and the LDS pressure relatively shows a darker color. And it's the vice versa with the expiration. Higher pressures intrathoracic and lower pressure at the LDS level. So this is actually the concept of the pressure inversion point that we need to document. But sometimes when we are dealing with a very tight achalasia, you are pushing the probe, the tip is stuck somewhere down there, and it is not crossing the LDS. Rather, the probe is rotating on itself. So this is the case where sometimes the interpretation can be all wrong. And the usual esophageal manometric findings are like a butterfly. How to overcome that? Try to pass the probe in a standing position. Ask the patient to raise the hands above the head. Ask the patient to take deep breaths. Sometimes we even use endoscopic guidance, but we have to be very cautious in that we can damage the very fine sensors of the probe. Now, in interpreting the esophageal manometry, 5 key matrices are very important. The very first one is the 4-second integrated relaxation pressure. That is actually the lowest average pressure during the 4 contagious or non-contagious seconds of relaxation in the 10-second window that is generated just after the start of the swallow. Usually the raised IRP cutoff vary according to the position you used or according to the system you are using. In my setup, I am using the Labori. So my cutoff values are in the supine 22 millimeter of mercury and in the upright 15 millimeter of mercury. However, the 4-second IRP has got a sensitivity of 98% and specificity of 96% in distinguishing a well-defined achalasia. The second matrix is the decelerated contractile point, the DCP. There are 2 emptying phases. The first one is the fast distal peristaltic velocity, followed by a slow progressing distal peristalsis. And the junction of these 2 phases is actually the deceleration contractile point. And we use this point actually to further enumerate the 2 more important matrices, including the CFV, that is the contractile front velocity, where you have to draw a tangential line from the proximal margin of the distal contraction to the DCP. The normal value is less than 9 centimeter per second, but if it is more than 9, then we are dealing with a rapid contraction. The second is the distal latency, where you draw an imaginary line from the start of the wet swallow and then draw a horizontal line from this imaginary line to the DCP point. This is a very important matrix that helps you to identify the premature contractions. Whenever the time is less than 4.5 seconds, you are dealing with a premature contraction. The next important matrix is the distal contractile integral, which is actually the strength or vigor of the contraction and can be determined by the product of pressure, duration, and length of the distal smooth muscle contraction. The normal value is from 450 to 8,000. If you have a value of less than 100, it's a failed peristalsis. For value less than 450, we are dealing with a weak peristalsis. And on the other hand, a value of more than 8,000 is depicting a hypercontractile activity. Another important point is if you are looking at the peristaltic wave, even with a normal DCI, there should be no large or multiple small breaks. So integrity is also very important. Chicago 4, the good thing is that has provided as a good protocol, a standardized protocol with which we perform the procedure in supine as well as upright posture with a 30-second adaptation period followed by a 3 deep breaths, then 30-second baseline phase, followed by 10 swallows in the supine and at least 5 in the upright posture. The Chicago 4 has 2 more provocative tests as well, that is a multiple rapid swallows and rapid drink challenge. The multiple rapid swallow is mainly used to determine the peristaltic reserve, especially in patients with low DCI or ineffective swallows. So a poor peristaltic reserve suggests that these patients might not respond well to the therapy. On the other hand, rapid drink challenge test is used whenever you have a tie between an achalasia and EJGOO, sometimes cases with inconclusive achalasia. So rapid drink challenge test helps that as the patient starts doing this rapid drink challenge, the IRP raises a lot, whereas EJGOO, the IRP usually do not raises. We can also classify achalasia with the help of manometry. Usually the IRP is raised with all achalasia subtypes, but the difference is within the body of the esophagus. If it's 100% failed peristalsis, you are dealing with a classic type 1. If more than 20% panesophageal pressurization is type 2, and if more than 20% premature contractions, it's a type 3 achalasia. This is one of my own study where we optimize achalasia diagnosis in the era of high resolution manometry in a Pakistani perspective. Out of 210 patients, 62% were type 1, 30% were type 2, and 8% type type 3. But the important thing is that 40% of these patients had a normal upper GI endoscopic findings and 13% has normal barium findings. The second thing was that the average length of time from the onset of symptoms till diagnosis was 4.51 years. So signifying the importance of manometry in diagnosing the achalasia. Another challenge to us is type 3 achalasia versus DES, that is the distal esophageal spasm. Practically speaking, the diagnosis is not that easy. Theoretically, although if we have more than 20% premature contraction with a raised IRP, it's type 3. With a normal IRP, it's DES. But actually, this is not that easy because there is a very well-known entity known as DES with the EJGOO. So esophageal gastric junction outlet obstruction caused by this spasm can sometimes raise the IRP and you can have a confusion it with an achalasia type 3. Practically speaking, in an actual type 3, there should be no peristaltic, no normal peristaltic activity at all. So the more premature contractions in a study, the more confidence you have that you are dealing with a real type 3 achalasia. Another modality is the ineffective esophageal motility. This definition has been upgraded in the Chicago 4 from the Chicago 3, raising the bar to 70% ineffective swallows or 50% failed swallows. And in the Chicago 3, we had this diagnosis in the minor set of motility disorders, but now it's a major disorder with more stringent criteria. Another my own study where I evaluated ineffective motility revisited through HRM4, and there were 71 patients of ineffective motility, where 57, that is 80.3, show concordance for the diagnosis between Chicago 4 and 3. But 7 patients after Chicago 4, they were no longer qualifying for the IEM criteria, thus reducing the estimated prevalence from 19.4 to 17.5%. On the other extreme, if you have a DCI of more than 8,000, you are dealing with hypercontractile esophagus. So for this, symptoms has to be very important. Patient has to be symptomatic. Chicago 4 encourages us to divide it into the 3 phenotypes, that is a repetitive prolonged contraction like a jackhammer, or a single peak hypercontractile contraction, or a hypercontractile with vigorous LES after contraction. This may have this may lead to some new research to see the response to the therapy in hypercontractile esophagus. Manometry, apart from classifying the motility disorders as per Chicago 4, can also give us clues beyond these motility disorders. Like, we can have an idea of the rumination syndrome with the documented rumination waves leading to the rumination of the food contents. Then hiatal hernias, very important. If you see that the LES can be easily distinguishable with the lower margin at like 46.9 centimeter. And the IRP, which I have discussed, is at 48.1 centimeter. So there is a clear-cut hiatal hernia of 1.2 centimeter in this case. So another important aspect is, or evolving debate is, the proximal esophageal parameters. Many parametric activities, many muscular things that can be highlighted with this as well. Not going into the detail of this, but just want to know that the pharyngeal motor activity can now be further subdivided, and maybe in Chicago 5, this can be the component involved or can be added to the new Chicago classification. GERD, reflux disease. Manometry, though it can quantify the EJG competence by determining the contractile integral as well as the anatomical morphology of the EJG, but still to date, it is just being used as an adjunctive test to diagnose the associated pathologies, to help surgeons pre-evaluate the patient for weak peristalsis or hiatal hernia. But in future, there might be quite a good role of it. Impedance, the second component, very important. It's a part of not only manometry, but the pH studies as well. So the concept is that the impedance is inversely proportional to the electrical conductivity of the luminal contents. When you have air inside the esophagus, it has got a low conductivity and it can increase the impedance. Whereas a swallowed or reflux material has a high conductivity and a decrease in impedance. But keep in mind that this impedance can be of two further subtypes. The first one is a typical esophageal luminal impedance, which you usually determine with the help of these typical intraluminal impedance probes. The technology is usually combined with either manometry or the pH monitoring. But another evolving concept is the impedance of the esophageal mucosa. This is a very interesting concept, and it refers to the baseline impedance of the esophageal mucosa. The lower mucosal impedance indicates a decreased mucosal integrity and therefore suggests mucosal damage or pathology. A dilated intracellular spaces and associated disruption of the tight cell junctions allow leakage of the ions, thereby decreasing mucosal impedance. This mucosal impedance can be measured in three different ways. The first one is the esophageal contractile segment impedance, where the CSI is measured as the catheter sensors are pressed against the mucosa during the passage of peristaltic contractions. This is one of my patients with reflux disease, and to determine the CSI, first of all, we have to mark the position of the esophageal gastric junction as indicated by the diaphragmatic crura. The CSI is usually determined 3 centimeter above this baseline, and at this landmark, we have to identify the point where there is the maximum pressure, like the peak pressure of 127, suggesting that this will be the point where the impedance sensors will be very tightly placed with the mucosa. So corresponding to this peak pressure, we determine the impedance, which comes out to be quite low, suggesting that the reflux is causing mucosal damage and leading to a decrease in the CSI. This CSI has been thoroughly evaluated. There are emerging studies on this. One of this study, which I'm showing over here, has proved that the CSI has got a very good acceptable area under the curve in distinguishing GERD from the non-GERD patients. To further increase the sensitivity, we can add straight leg raising with the CSI as well. The second method to determine the mucosal impedance are the specially designed mucosal impedance probes. They are not commercially available, but experimentally, yes, they are there. The probe can be passed through the endoscope and can be touched at the area where you want to determine the impedance. So targeted impedance. Dr. Shahid Rasool has discussed the eosinophilic esophagitis and where the mucosa is damaged, and the GERD patients. You can compare the point impedance in these two cases versus the normal impedance in achalasia and non-GERD patients. Okay, last but not the least, last segment, the pH impedance testing, which is the current gold standard for diagnosing the reflux disease. Indications we all know, especially patients who have got atypical symptoms or not responding to therapy. There are 4 different possible types of refluxates according to the pH. One is an acidic refluxate where pH less than 4, then an acidic re-refluxate, which is superimposed acidic reflux when pH was already less than 4. So it was a refluxate during an acid clearing interval. Then a weakly acid refluxate where pH is 4 to 7, and then a weakly alkaline reflux where the pH is more than 7. The last two cannot be measured without the help of impedance. So how we perform it? We use the catheter, calibrate it with the acidic as well as alkaline buffer, wash it thoroughly, and then place it through the nose inside the esophagus with the distal end 5 centimeter above the LES, anchor it there, and then we send the patient home with a diary to keep records of the events. And after 24 hours of the ambulatory testing, the test is stopped and then connected with the system to analyze the data. This is a picture we get after the 24-hour data with 6 sensors, Z1 to Z6, and the pH sensor at the underneath. The system itself tells us all the reflux and swallow events automatically, but we can analyze each and every event separately. A typical acid reflux is when there is an impedance value drop in a retrograde fashion, along with a drop of pH from 7 to less than 4. This is a typical acid reflux, and as per Lyon consensus 4, if you have an acid exposure time of more than 6% in 24-hour study, it is conclusive for the reflux disease. If acid exposure time less than 4, it is against reflux disease. But sometimes you have an acid exposure time of 4 to 6%, then it is a borderline. Sometimes you have non-acidic reflux states where the impedance fall is in the same way, but the pH does not drop. For these sort of cases, you will have a supportive evidence of reflux if there are total more than 80 such reflux states in your study. But if you have a 40 to 80 reflux states, then that signifies a borderline reflux disease. Post-reflux swallow-induced peristaltic wave index, this was the index quite commonly being used in the Lyon 1 consensus. It's an important index, but now in the Lyon 2, it has been removed. But the concept is that after impedance, the post-impedance swallow determines that how good the clearance of the patient is, and it can be well correlated with the prolonged contact time of the esophageal mucosa with acid and inversely related with heartburn sensitivity. My last slide, this is the mean nocturnal baseline impedance. It is the third way to determine the mucosal impedance. And this is a part of Lyon 2 consensus as well, where the pH is traced in the 10-minute window during the night time around 1, 2, and 3 p.m. And if the mean is less than 15 ohms, this supports the evidence of reflux disease. But if it is above 2500, it is against the reflux disease. So that was all from my side. Thank you very much. We are routinely performing the manometries at our center, Center for Liver and Digestive Diseases, not only esophageal manometries, the pH testing, but also the anorectal manometries. This is our data for the last 10 years, more than 500 motility disorder patient registered. So thank you very much for your patient listening.
Thank you, Dr. Tayyib, for simplifying the complexities of manometry interpretation. I am confident that our audience will feel more comfortable understanding and applying this diagnostic tool in their practice. The house is now open for questions or any comments. Any comments from the chairs?
Appreciate the speakers for their brilliant presentation. I have a suggestion. We here in KP don't have any manometric services. I request the PSG forum to send someone consultant who is interested in pH monitoring to learn and come back and establish the services in this province.
Another comment is that it is a very important topic considering that the dysphagia is something that is often delayed as a diagnostic dilemma, because the average time a patient spends from onset of the symptoms before being referred to us, the gastroenterologist, is usually 3 to 6 months, and at times even longer. So first of all, there is delay in endoscopy, and then if the endoscopy is normal, people usually do not biopsy and just start empirical therapies. And later on, when nothing works, biopsies are done, then they are normal again, patient is just laid down and not discussed any further. And so there is an ultimate delay, like Dr. Tayyib said, that people come to him with an average delay of 4 years. So these are the delays. So I think it's very important to raise the awareness among physicians to send dysphagia cases on priority for endoscopy regardless of the age.
Thank you. Yes, sir. Mike. Mike, sir, को दे दें.
Not a question, but a comment to make. One of my not a question, but a comment to make. One of my patients, I think it was a couple of years ago, had problem with esophageal motility here in Peshawar, and I asked her to get the studies done in Holy Family Hospital. So eventually she WhatsApped me the report, and I didn't have a clue because I'm not a motility expert. But I'm really proud to say that when I showed it to our motility expert, he was very impressed with the tracing and the interpretation. So so really felt proud of you.
Okay, thank you for all the speakers for their enlightening talks and cheers for their comments. And now we move forward to formally to invite Dr. Kamran Hassan and for his concluding remarks. Dr. Kamran's.
Bismillah ar-Rahman ar-Rahim. On behalf of Pakistan Society of Gastroenterology and GI Endoscopy, I am really thankful to all the distinguished faculty from the different parts of the world. It was a success because of your presence and the scientific content which was displayed here and shared with the audience, with our delegates, with the doctors in this part of the world was extremely, high valued content. And all of the speakers, either from abroad or from different cities of Pakistan, they done really well to, make it a success. And I think it was a landmark scientific content which was shared with us. I'm really grateful with the deep core of my heart for your presence here. You spared your precious time. You honored us. You came all along from different cities of Pakistan and from different countries of the world. And Pakistan Society of Gastroenterology and GI Endoscopy will definitely want to collaborate with all of you in the future as well. As our future next year conference is going to be held in Serena Hotel, Islamabad. I hope that it will also be a landmark conference because it is the capital city of Pakistan with a huge infrastructure and the weather in Islamabad is much pleasant than weather in Peshawar in those days. And I hope you all will come again and will honor us once again. We now have the closing ceremony, and I request all the presenters of the oral papers to come forward. I hope all of you are present. Can you please raise your hands? All of you are here, 6 people. Dr. Wakas, are you here? Can you come please and let us know their names so that we give them certificates of appreciation along with the prize money. Is it ready? Achha.
4 oral presenters, 1 3 oral presentation by a single person, and 3 by other separate persons.
Sahi, theek hai. I request Professor Sher Rahman, President, Pakistan Society of Gastroenterology, Professor Waqar Ahmed, Professor Saad Khalid Niaz, and Professor Khalid Hamid to kindly come on the stage. Prizes were open on the stage. Wagas, you proceed.
So now I'm going to invite Dr. Muhibbullah. If he is present, he has presented 3 studies as oral presentations. Dr. Muhibbullah from Nashtar Hospital, Multan. Dr. Muhibbullah is currently has been selected for residency in the US and West Virginia. He presented today 3 meta-analyses that were of high quality, and we hope that in future he will continue his efforts. Yes. Yes. So that was Dr. Muhibullah from Nashtar Hospital, Multan. Now Dr. Mehboob Jan from SIUT, Karachi. He presented today a paper on factors predicting lean non-alcoholic fatty liver disease in Pakistani population, and it was a great paper, and we hope that he will produce such high quality papers in future. Thank you. Dr. Nida Rasool, if present, yeah, so you can receive on her behalf. Again from SIUT Karachi. She presented the paper of predictors of frailty in patients with hepatitis C associated liver cirrhosis. Again, it was a great paper, and it would be a great addition to the new scientific literature. The last oral paper was also from SIUT Karachi, Dr. Danish. You can receive on their behalf if he is not present. So big round of applause for SIUT Karachi because they presented 3 oral papers. Thank you so much. Thank you so much, Professor Dr. Saad Khalid Niaz, Professor Dr. Wakar, Dr. Khalid Hamid, and Professor Dr. Sher Rama.
Now I request the president, our new president, Professor Saad Khalid Niaz, to come on the stage and express his views regarding the vision of Pakistan Society of Gastroenterology.
Bismillahirrahmanirrahim. First of all, I would like to congratulate the whole team led by Professor Sher Rahman and Dr. Kamran, KPK, and everybody from KPK for organizing a very good, well-organized, and full of food meeting. The food was very, very special, but the thing that I'm sure all of you would agree, the timings that I've seen in this meeting are very rarely followed in meetings in Pakistan. So that is commendable. The whole content of your scientific content of the meeting had a theme, had some thinking going in. So every talk was kind of following a theme, which again is very good. And I think the attendance from our national colleagues as well as your provincial colleagues has been fairly good. And I set a milestone. They've set a standard that Islamabad, inshallah, will follow and hopefully do better. The meeting of PSG has been announced, and it'll be 9th to 12th of April 2026, a year from now almost. So please make a note of that date. You'll have more details. I don't know how many of you are actually active members in the PSG, but I think it's very important because we are on our way out. I've been involved in the society since I came back to Pakistan in 2001, and there are people who've been involved longer than that. But the society will only survive if young people, Kamran's age group, and the younger people even, who need to take over the society and actually take it where it belongs. 41 years ago, Kal Sadiq Shah Sahab ne, when he was talking, it was really music to everybody's ears, where the society was about 39 years ago. We've actually not really progressed. And we need to work hard to make it, give it the status, the standard internationally that I think the society and the people working in gastroenterology in Pakistan deserve. Couple of things, because I'm sure some of you are not there. We are now working on some of the things that was decided in the General Body meeting. We'll have international members, and we will have a drive to for the Pakistanis. So if you have friends, colleagues who are gastroenterologists working overseas, they should become member of our society, and that way we can interact with them. You know, people who are going for fellowships or training, people like Dr. Wakar here have been very, very helpful to us. And so if we get more people involved and younger people involved, it will be great for our fellows. And I think the whole focus of our society has been in the last couple of years, and hopefully even more, will be on the fellows, on our junior colleagues. That's what we want to invest. And that is what our focus is. So if you have any issues, the new fellows, regarding membership, regarding scholarships, I think PSG is the forum that you must be involved with, and you must contact in your respective chapters wherever you're staying. So you don't even have to contact the central office. The other thing that we are hopefully working on, and Islamabad may be the first one, that we may be inviting, we'll try and invite other countries to join us in our national meeting. And if we are successful in inviting them, and if they come, especially Bangladesh and Sri Lanka, then we will form a group which will become an international group. And I think we'll be able to learn and share more with them than anyone else. So those are some of the things, and we'll reorganize things. I mean, Sher Rahman Saab has done a great job. It's difficult with all the clinical work. So the whole team that has come with me, I'm sure we'll try and do our best to give the society the status that it deserves. I once again thank you all for being here and being part of this meeting. Any issues, those of you who know us, fine, know me directly. Otherwise, Sher Rahman, Kamran Sahab, and every respective vice president of the chapter. For the younger crowd, this is the most democratic society probably there is in the country, even more than the Democratic Party, so-called. Because there are elections every 2 years. There are 5 chapters. So KPK is one, Balochistan Federal Chapter, Sindh, and Punjab. The meetings rotate every year. So you get a chance every 5 years. The meeting comes to your chapter. The president and the office bearers are elected every 2 years. So nobody controls, or nobody is a permanent patron or permanent president or whatever in this society for the last 41 years. And I think that's something we should all be very proud of. This is a society which allows everybody and anybody who's interested in running the society to stand up and actually take it further. So with that, I would like to thank you and thank you for giving me this opportunity.
Kamran, can I just make a comment before you say more important thing? I think we need to introduce a subscription for especially our overseas members and create an overseas membership forum. Because, if you get a subscription in pounds or dollars, it will strengthen your own funding. And then PSG can be more in a position of funding research, funding visiting scholarships and things like that. So personally, being an overseas member, I would propose a regular subscription. And the best way to do that is to make it easy online. And, I'm sure there are many ways. You have got young people who are very computer and IT savvy that make it easy, but simple, but make so that they make a significant contribution to the treasury of PSG. This would only strengthen our position.
Very much, sir. There are so many ways, like for us, it's an honor. Then you people come, you honor us, and I remember Professor Wakar never asked us for a ticket. Like, this is a great contribution to PSG. He's coming us without, spending any money from our side. I think this is enough for us. We don't need any further subscription charges, I think. If the overseas, yes. एग्जैक्टली तो ये डिसाइड कल एग्जेक्टिव बॉडी मीटिंग में भी हुआ है कि جو اوورسیز پاکستانیز ہیں اور دے آر سپورٹنگ PSG. تو ہم جو ہے تو ان کا ایک پورا گروپ بنائیں گے اور ریسرچ میں، ڈیولپمنٹ میں، انوویشن میں، فیلوشپس میں. اب سر نے بات کی ہے پروفیسر سعد خالد نیاز صاحب نے ریسرچ کے بارے میں. تو ایز اے وائس پریزیڈنٹ پاکستان سوسائٹی آف گیسٹرونٹرولوجی اینڈ جے انڈاسکوپی خیبر پختونخوا، الحمدللہ ہم نے پچھلے 2 سالوں میں 3 جو ہے نا اپنے جونیئر اسکالرس کو، فیلوز کو ریسرچ فیلوشپ کے لیے بھیجا، ہم نے اسپانسر کیا، جو انفارچونیٹلی کل کی اینول رپورٹ میں مس ہوا. باوجود ہم نے بھیجا ہوا تھا لیکن وہ شو نہیں ہوا. 3 ہم نے الحمدللہ ریسرچ جو ہے تو ہم اپنے فیلوز کو اسپانسر کیا ہے فیلوشپ کے لیے، اور دے آر سرونگ ناؤ 1 سال کے 6 مہینے کے. اسی طرح جو ہے تو ہمارا جو فیلو تھا ڈاکٹر وکاس، وہ جو ہے تو ریکمینڈ ہوا جاپانی سوسائٹی آف گیسٹرونٹرولوجی کی طرف سے ایز اے ریسرچ اسکالر ٹو جاپان. ہی اسپینڈ 5 months there and he has this laurel. He has come to the country with lots of new things in his mind and good hands. So he will transmit those things to our younger generation as well. He is himself young, but یہ اسی طرح transmit ہوتا رہتا ہے. I was sponsored by PSG and was given travel award and fellowship in Japan in 2014. We have lots of connections and friends in the Japanese community, and it is a great honor that some Japanese come to Pakistan in this situation. پاکستانی میرے سے پوچھتے تھے کہ بھائی وہ تو لیول 4 ہو گیا ہے تو ہم آئیں کہ نہ آئیں. اور جاپان سے اگر کوئی بندہ آتا ہے اٹ مینس کہ دے ٹرسٹ ان اس، دے بلیو ان اور فرینڈشپ انسٹیڈ آف دیئر گورنمنٹ سیئنگ کہ یہ ڈینجرس ہے، لیکن وہ پھر بھی آ رہے ہیں. تو یہ ایک لنک ہے، کنیکشن ہے، ایک وہ ہے، تو اسی وجہ سے یہ لوگ آتے ہیں. تو مجھے یقین ہے انشاءاللہ کہ مستقبل میں ابھی ہم نے ڈیسائیڈ کیا ہوا ہے کہ ہم جو ہمارے 2 سینٹر آف ایکسیلنس ہیں، ایک سیاگ ہے اور ایک جو ہے نا غیاث النبی طیب کا ہے. تو پروفیسر سعد خالد نیاز صاحب اور غیاث صاحب نے کمٹ کیا ہے کہ پیورلی میرٹ بیس پہ جو PSG کے گڈ اسٹینڈنگ ینگ فیلوز ہوں گے ہم ان کو روٹیشنز دیں گے، لیکن ان کے ساتھ یہ کمٹمنٹ ہوگی کہ دے ول ورک فار PSG. وہ PSG کے لیے کام کریں گے. یہ نہ ہو کہ PSG ان کو ٹرین کرے، ان پہ اسپینڈ کرے، ان پہ انویسٹ کرے اور وہ آگے جا کے نہ تو ملک میں کوئی دنگا فساد پھیلائے. اٹ شوڈ بی لائک سم تھنگ کہ وی وانٹ ٹو اسٹرینتھن PSG. مطلب PSG کو اسٹرینتھن کرنے کا یہی طریقہ ہے. یہ جو سیلف پروجیکشن ہے وہ بڑا ویزیبل ہوتا ہے. جو لوگ سیلف پروجیکشن کے عادی ہوتے ہیں وہ بڑے جلدی ویزیبل ہو جاتے ہیں. تو سیلف پروجیکشن نہیں ہونی چاہیے. اٹ از اے سوسائٹی فار دا بیٹرمنٹ آف دا گیسٹرونٹرولوجی سروسز ان پاکستان. اٹ از ناٹ فار پروجیکشن آف اور اون سیلوز. مجھے یاد ہے شاہ رحمان صاحب مجھے ہمیشہ کہتے تھے کہ میں نے صدر نہیں بننا، لیکن ہم نے کہا کہ بھائی آپ ینگ ہیں، آپ انرجیٹک ہیں، آپ کمیٹیڈ ہیں، آپ سائنٹیفک اپروچ ہے آپ کا، آپ نہیں بنیں گے تو کون بنیں گے؟ تو یہ نہیں بن رہے تھے. میں قسمیہ کہتا ہوں ہم نے ان کو پکڑ کے بنایا صدر. اور الحمدللہ آج اگر PSG جنرل ہے، ریویو ہوا ہے، اس کا کریڈٹ شاہ رحمان صاحب کو جاتا ہے. اس کا کریڈٹ جو ہے تو وہ مسلم عتیق کو جاتا ہے. اس کا کریڈٹ بعد میں ان لوگوں کو جاتا ہے، پہلے ان کو جاتا ہے. اس لیے کہ 12 سال سے یہ جنرل ڈورمنٹ پڑا تھا. بہت سارے پریزیڈنٹ آئے، بہت سارے لوگ آئے، یہ کیوں نہیں ایکٹیویٹ ہو رہا تھا؟ اب اگر ہوا ہے تو اس کے پیچھے کوئی فورس تھی نا، ایک لیڈرشپ تھی، ویژنری، جنہوں نے سوچا ہے، جنہوں نے پلان کیا ہے، جنہوں نے ایگزیکیوٹ کروایا لوگوں سے، تبھی یہ ممکن ہوا ہے. تو جو ریئل کریڈٹ ہے، ہسٹری شوڈ بی ریٹن کریکٹ. اگر ہم اپنی ہسٹری کریکٹ نہیں لکھیں گے تو ہمارا پریسیڈنٹ غلط جائے گا. تو ہسٹری کریکٹ ہونی چاہیے. اور ہم ادھر سیلف پروجیکشن کے لیے نہیں ہیں. ہماری باری آئی تھی، چلی گئی. الحمدللہ اب نئے لوگ آئیں گے اور مجھے امید ہے کہ وہ اسی لیگیسی کو لے کے آگے جائیں گے. یہ نہیں ہوگا کہ اپنی تصویریں لگاؤ، ہم نے یہ کیا، ہم نے وہ کیا. جو کام کرتے ہیں وہ دکھتے ہیں، ان کو دکھانے کی ضرورت نہیں پڑتی. تو یہ شوشا، یہ ڈرامہ بازیاں ختم ہونی چاہیے. لیٹس کم ٹوگیدر اینڈ وی ورک ٹرولی فار دا ٹرو کاز آف دس نیشن. تو وہ سینس ہوگا تو ہم ینگسٹرز کو سپورٹ کریں گے انشاءاللہ. اور جتنے بھی ینگسٹرز ہیں، جن کے بھی گلے شکوے ہیں، یہ گلے شکوے ختم ہونے چاہیے. اٹ از یور سوسائٹی، یو اون دا سوسائٹی، یو آر دا لیڈرز. اف یو ہیو کمٹمنٹ، اف یو آر ڈیڈیکیٹڈ، اف یو آر سنسیئر ٹو دا سوسائٹی، نو بڈی کین اسٹاپ یو فرام ایکسیلنگ ان یور فیلڈ. اور سوسائٹی آپ کو پورا طرح سے، ہر طرح سے آپ کو سپورٹ کرے گی انشاءاللہ. میں اس وقت ایک اسپیشل بات کرنے جا رہا ہوں. We have at least 12 colleagues from Afghanistan. I am thankful they are here. Afghan malgaro tasu ta har kali wayama o tasu dozmonga runayai tasu zmung vinayai zmung runayai mung ba har kisma support darkau. We will support you, we will guide you, we will train you. Don't worry. PSG, you become foreign members of PSG. We also are thinking of that. तो इंशाल्लाह हम आपको पूरा जो है ना स्ट्रक्चर्ड ट्रेनिंग प्रोग्राम शुरू करेंगे. हमारा मकसद ये है कि हमारा जो बरादर इस्लामी मुल्क है वो भी डेवलप हो, उसमें अच्छे अच्छे सेंटर्स बने, ताकि वो गरीब लोग जो बेचारे उधर बॉर्डर पे खड़े होते हैं, उनको वीज़ा नहीं मिलता और भेड़ बकरियों की तरह उनके साथ सलूक किया जाता है, उनको अपने मुल्क में इज़्ज़तमंद तरीके से लोग ट्रेन कर सकें. ये हमारी विज़न का हिस्सा है और मेरी कमिटमेंट है. सर भी बैठे हुए हैं, हमारी सीनियर टीम बैठी हुई है, हम सब की कमिटमेंट है, इंशाल्लाह ऐसे ही होगा. अच्छा, अब मैं एट द एंड बिकॉज इट्स अ क्लोजिंग सेरेमनी, मेरा यह है कि अगर किसी भी हमारे कोलीग जूनियर या सीनियर के जहन में कुछ भी है, अगर वो कोई सजेशन देना चाहते हैं, कुछ लिखना चाहते हैं, तो वो काइंडली हमें लिखें, हमें सजेस्ट करें कि सर ये तरीके से हम इसको इम्प्रूव कर सकते हैं. इट्स एन ओपन फोरम. उसके लिए भी हम एक PSG वेबसाइट पे आपको बता देंगे कि भाई आपने किसको डायरेक्ट करना है, कैसे लिखना है, और आपकी सजेशन के लिए कमेटी होगी, वो कमेटी उसको रिव्यू करेगी. उसमें जो भी चीज़ फिजिबल होगी, प्रैक्टिकल होगी और जो है तो इम्प्लीमेंटेबल होगी, मतलब एक होती है हवाई बातें, एक होती है काम की बातें, तो काम की बातें हम लेंगे और उसको कोशिश करेंगे कि हम सोसाइटी को उसी हिसाब से इम्प्रूव करें इंशाल्लाह. ये वाहिद सोसाइटी है इस मुल्क की जो मुल्क के हर कोने में मौजूद है, और जैसे कि सर ने बताया कि ये डेमोक्रेटिक सोसाइटी है, वाहिद सोसाइटी. मुझे यार कौन प्रेसिडेंट बनाता अगर PSG ना होता. PSG की वजह से मैं प्रेसिडेंट हूँ, आप लोग मुझे पहचानते हैं. PSG की वजह से मैं जापान चला गया, PSG की वजह से मेरी आज इज़्ज़त हो रही है. बहुत सारे लोगों को PSG ने ऊपर लाया और उन्होंने अपनी सोसाइटियाँ बनाई. ये कल्चर ख़त्म होना चाहिए. अगर आपको PSG ऊपर लाती है, आपको इज़्ज़त देती है, आप PSG को इज़्ज़त दें. इज़्ज़तदार लोग ऐसे ही करते हैं और मुझे यकीन है कि हमारे सब लोग अल्हम्दुलिल्लाह इज़्ज़तदार हैं और ऐसा जो है ना कोई भी नहीं करेगा मुस्तकबिल में. तो अपने सजेशन लेके आएँ, अच्छे सजेशन लेके आएँ, हमें लिखें, हम उसके लिए प्रॉपर वर्कअप करेंगे और कोशिश करेंगे कि हम इन चीज़ों को इम्प्रूव करें. एट द एंड चूँकि इसके बाद हमारा लंच होगा, तो मैं एक मरतबा फिर आप सबका बहुत बहुत मशकूर हूँ, तहे दिल से मशकूर हूँ कि आज इतवार के दिन आप इतनी बड़ी तादाद में यहाँ पर मौजूद हैं. ये अल्हम्दुलिल्लाह आपकी जो है ना मोहब्बत है कि हमारा ये प्रोग्राम सक्सेसफुल है. मैं प्रोफेसर शेर रहमान साहब से रिक्वेस्ट करता हूँ कि वो जो है ना आखिर में वोट ऑफ थैंक्स सबको दें और दुआई कलमात भी हों, तो इख्तिताम मुझसे हो. प्रोफेसर शेर रहमान साहब.
मेरे ख्याल में काफ़ी बातें हो गई. आप लोगों का बहुत बहुत शुक्रिया. इतवार का दिन है, आप लोगों की भी मसरूफियात थी.